Ladies and gentlemen, let's welcome our MWS Uncommon Dialogue moderator, Mr. David Wong, and our distinguished panelists to the stage, please. During the discussion, if you have any questions, please submit them via the QR code on the screen. Thank you.
Good afternoon, everyone. Thank you for coming for this event. We have a very distinguished panel here, and I must congratulate the MWS staff for inviting them. Mental health is a topic that's often discussed these days, and this is a wonderful opportunity for us to find out a little bit more about this topic, which is often, swept under the carpet, I think. So, on the other side of this panel here, I've got Professor Heok. He's got a resume that's an arm's length long, but in short, he's the Emeritus Professor of Psychiatry at NUS. And he was previously the CEO and Medical Director of IMH. But he has served the community in many, many areas, and the country has recognized his service with a PBM, a Public Service Medal, and a Public Service Star as well. Well done, Prof. Kwa. Thank you for being with us. Okay, on my side here next to me, Dr. Ng Wai Chong. He's a practicing community-aged care physician, and he's the founder and CEO of a longevity practice. Okay, so if you want to live longer, this is the man to talk to. And Wai Chong volunteers a lot of time at charities, government committees, okay, that in particular focus on support and care of vulnerable adults and older persons. So, he brings a lot of practical experience to this panel. Thank you for joining us, Wai Chong. And there in the middle, I've got Dr. Raymond Leong. Raymond is the Group Director of Healthcare Services in MWS. Okay, so he can tell us in particular about what MWS offers in this area of mental health for seniors. But before joining MWS, he was the health advisor for Shell Petroleum and also the medical director in clinical affairs at Sao Foundation. Thank you for joining us, Raymond. Okay, before we get into this, I should tell you that this is a panel, so I do really invite questions and comments. You don't have just to ask questions. If you've got a view you want to share, please do share it. All right, so we hope it'll be as interactive as possible. There are mics around, so please feel free to stand up and engage the panel. If you're a little shy, we do have a pigeonhole, all right? We do have a pigeonhole facility, which I think you can scan that QR code. That'll give you access to Pigeonhole. And you can submit your questions online. I'll have a look at them, and I'll find an appropriate time where we can put the question to the panelists. Okay? So please respond we have about an hour, so please respond as actively as you would like. Ask all the questions, the comments that you'd like to make. I know the panelists have a short presentation for us, but I thought before I invite them to share their views, I'd ask them to perhaps help introduce the whole subject of mental health to us. Is there a difference between mental health and mental illness? Okay, I go and swim. I swam this morning, all right, in an attempt to try and promote physical health. But I also suffer from colds. I get sick. Maybe I get a pain in my knee, all right. Sprained ankles, or else a chronic disease, perhaps a cancer, a heart condition. Is mental health, do we look at it in the same way? Mental health and mental illness, are these conditions treatable or are they just manageable? Is there a tablet I can take to solve it? I don't know. Prof. Kwa, would you like to lead us in this? Just introduce the subject to us.
Thank you, David. The definition of mental health was discussed in a World Health meeting. I was at that conference some 35 years ago. What is mental health? So we reckon that if someone can function well, like if you're enjoying your food now, you're able to enjoy the nice music, the Cantonese opera, and you had a good sleep last night. Do you all have good sleep last night? Right. The commonest mental health problem in my clinic is, doctor, I can't sleep, I used to run a very busy clinic, NUH, now at the Farrer Park, So if you have trouble sleeping, whether you have a physical health problem, whether because you have backache, like David, it affects your mental health because next morning you wake up, you can't function well, you cannot focus, right? But mental illness is a bit different.
So physical health and mental health are related, are they?
That's right. People call it the double helix. You remember the double helix about chromosomes? They're both linked, So sometimes patients with heart problem become very anxious. So they come and see me also, or people with cancer also have a lot of anxiety, depression. I once looked after somebody from the bank, a lady in the 40s, a Christian family, and she had cancer, and then she became very, very angry. She was so the oncologist said, I think I better send this lady to see Professor Kwa. So I spoke to her. She said, I wonder why God is so unfair to me. I've got a wonderful job in the bank, and I have 2 kids, and now I'm down with cancer of the breast. And she told me something which I remember to this day, which I use it for the editorial I wrote. It's called, what she said was, the pain of the body, the pain of the mind is worse than the pain of the body. She said, I can tolerate the pain, but the thing about, if I were to go off, what happens to my 2 kids, And she became very angry with God. She's the wife of a pastor, So he went to therapy, and towards the end, she was better for 6 months. And she felt a bit remorseful. She said, why can I be so angry with God? But the time of your life, right? So there's a difference between mental health and obviously illness. You have symptoms, depression, you can't function, you can't enjoy your food now, not sleeping well, all kinds of strange ideas that you have, that maybe God is against you. This is mental health.
Thank you. Raymond, you want to add anything?
Thanks, Prof. So, from my perception, mental health and mental illness are 2 sides of the coin, like what Prof mentioned, the double helix. Mental health focuses on health, as the word suggests. So, in our current context right now, especially in this day and age in society, I think health is something that we all want to aspire to have.
So how do we promote mental health? Is it doing crossword puzzles?
Absolutely.
Is
in
that
fact,
right?
I think Prof. Kwao hit the nail on the head, right? Health is something that we aspire to achieve, and in aspiring to achieve that, we want to do something that we enjoy. So it can be crossword puzzles, right? For me, it's a good night's sleep, right? And it can also be swimming or running, anything that makes you
So
enjoy.
exercise also promotes mental health.
Absolutely. And for mental illness, is a focus on the debilitating side of health, right? And we are trying to shy away from that. So mental health and mental illness are actually synonymous, but the focus for me is very different.
Wai Chong?
Well, when I was in the hospital working as a doctor, and then I became a GP, I run a clinic, the focus was on the disease. But when I became a home care physician, visiting people at their home, and I realized that I cannot afford to just focus on the disease, that's when I realized that mental health is everywhere. To every physical illness, there's a mental distress associated with it. So because of that, I do live and breathe mental health as a community physician looking after the aged and the frail and the caregivers. One of the things I discover is that health is not merely the absence of disease, and that the health is related to the ability to do things that we believe is meaningful. That is true for physical, but it's also the same for the mind. So I would say mental health is really about the ability to manage. So even the fact that as we age and get frail and suffer from different kinds of diseases that sometimes you can feel really, really helpless, the ability to manage is the mental health aspect of it. Some people call it resilience. So there's a
So
science
there's a
around
difference between
salutogenic.
treatment and managing a condition, right?
Yeah. Yes.
Okay, good. Okay, maybe now I'll invite the panelists to share their thoughts. I'm going to ask Raymond to begin with an overview. He's got a couple of slides, right? You got?
So, I'll be starting off. Is there, is it? Oh, is someone going to click for me?
No, if you want a clicker, it's on the
okay.
rostrum. If you
Right.
don't need the clicker, it's all right.
Yeah. So I think, in fact, I was just having the pleasure of speaking to some of our attendees today. And I think one of the questions they were asking, based on their own personal experience, was that they had difficulty actually finding services in the community. And I think we had a candid conversation, I think it was now Jonathan, who said that, if you want to actually be right-sighted to the services, the best place to be at is the hospital. Because the hospital have all your resources, right? And has everyone there who is able to do that facilitation and arrangement of all these services. Because once you are out there in the community, sometimes you feel very alone. Sometimes you feel that you're unsupported. Sometimes you don't know where to go to find these services. And I think one good news is that the government recognizes that. And with these initiatives that I think a lot of people in this room will be be familiar with, is that we are starting to hear things like Healthier SG. We are starting to hear things like Age Well SG. And all these are national level initiatives to help us to understand a little bit more about what services are out there, which services are mainstreamed, and how can we actually find these services. So my next two slides, very quickly, is to actually look at an overview of these community health services. And that goes beyond the hospital, of course. So a bit small for those at the back, but basically why it was made as such is because we are trying to see how we want to segmentize the availability and the provision of services in the community. So not everybody needs a very high level of mental health intervention, right? Unless you are in distress or in crisis. So if you're looking at the left side of the slide, whereby your focus is actually more on primary prevention, or as what I call it, primordial prevention, whereby things haven't even started yet. You're really looking at the psychosocial aspects of health, right? And like exactly what Prof mentioned, exactly what Mr. David mentioned about and Dr. Ng as well, how we actually do things that focus on health rather than focusing on the disease. Now that is exactly how the Singapore government is segmentizing our services in the community. So it's broken down into 4 tiers. So as you can see, tier 1 is of course your basic tier, which is your primordial prevention. Tier 2, primary. Tier 3, secondary. And tier 4, tertiary. And if you look at how it is being segmentized in terms of services, when you are really thriving in the community, you and I, right, healthy, young adults, okay? So we are looking at services like active aging centers, right? We are looking at the Healthcare Promotion Board giving you all of us awareness. You're looking at grassroots. These are your signposts in the community to sort of help you in terms of the very basic prevention of mental health and the promotion of mental health in the community. Now, of course, once you have some signals of having a little bit of distress, maybe like what Prof said, you're having a bit of difficulty sleeping, then perhaps that is when you realize that, hey, maybe I need to reach out for help. But do I really need to go and see a psychiatrist? Or do I really need to go and see a psychologist? Maybe that's not really necessary, right? So who do you go to look for? There are actually mainstream services by AIC currently. And as you can see on the screen, there's these services called cusp. So cusp is a mainstream service by AIC right now that actually looks at more awareness and education. So when you reach out to teams like that, they can actually teach you how to maybe manage your lifestyle better, maybe how to live better, focus on your social lifestyle to sort of make sure that that if you don't do anything solid about it, you may actually go to tier 3, So tier 3 is when these are really the community services that are in the community right now, like GPs, polyclinics, right? You also have a mainstream service called COMIT, C-O-M-I-T, as you see on the screen. You also have, nursing homes, right? They are able to provide that kind of service in-house as well through psychiatric day rehab or day care. And these are the ones that help you to manage mental health conditions that have already emerged, but are not at the crisis level. And last but not least, of course, when you reach a crisis, you have your tier 4 that supports you in terms of the hospitals and the specialist outpatient clinics. Now, if you look at the right side of the slide, why this arrow was being drawn is because the whole premise of us building the whole ecosystem for the community is for us to actually go towards tier 1. And all of us sitting in this room today, and I think just now Kelvin shared his personal story about his family, right? Is that we know that as we age, mental health issues will crop up. And at the same time, how are we trying to shift the curve towards tier 1 so that we do not go into crisis? That is the part that all of us have to work as a society to achieve this. It cannot be AIC, it cannot be MSF, it has to be whole of society, because as we know, health is determined at least 80% by your social determinants. It's not about, what kind of health-seeking behaviors we go for. And you will see that your quality of life and also dailies, this term, as you see there, DALYS, for those who are unsure of this term, is called disability adjusted life years, right? So for each condition or mental health condition that we get, the burden in terms of the disability that will impede on our lifestyle, on our lives, increases, right? So as we achieve towards tier 1, effectively, we will decrease the disability adjusted life years, we will increase the quality of life, right? And that is what we should be heading towards. Yeah. So that is basically a brief of all the community services.
Thank you, Raymond.
Yeah.
There's one other aspect of mental health and mental illness is that many of these conditions, I think, are quite chronic. I mean, they last a long time. And so there's another word, in this whole discussion which we need to introduce, and that is caregivers. Okay, because the issues really the burden falls on the caregivers. What do I do if a loved one is suffering from a condition, right, where he's no longer what he used to be, right? Or she can't function. How can I get help? What kind of support? Because the burden of caregiving is a big issue. I know Wai Chong is particularly passionate about this. Would you like to share any thoughts, Wai Chong?
I also have a presentation. There are two parts to it. The second part is about caregiver stress and the dynamics, the causes and conditions behind it. But before that, I'd like to discuss about how aging leads to mental stress for oneself and our caregivers. And by going through this, I hope we can sort of have some insights, how do we prevent, how do we manage both the mental stress of a person who is aging as well as the stress of a caregiver. So it's like this. The question I'd like to ask, and also just now David posed this question, must we always have mental distress as we age? So, let's just see. This is a hypothesis. Let's say aging leads to health, physical health decline. Currently, even with the latest in aging biology and all that, this is still quite true, that aging, because of the instability of our genomes, our genetics, and the fact that in evolution, there is no selection for people who live longer. You just need to live long enough to reproduce. So in a way, there is an evolution blind spot. There is no selection for organisms that live longer. And also for the genes, there's always mutations happening as we live because of exposure to UV light, because of the things we eat, because of not exercising, because of obesity and so on. So, and also the shortening of telomeres when the cell divides. So aging will necessarily lead to the loss of health reserve. The meaning of loss of health reserve means, like when we are younger, if you have a flu, you can still work. But when you are older, you catch a simple cold, you may not be able to get out of bed. So that is the idea of health reserve. But health reserve is not always just merely our biology. It's also related to our behaviors, right? Do you smoke? Do you drink? Do you exercise regularly? With the loss of health reserve, it's very likely that we will catch the chronic diseases such as diabetes, hypertension, lipids, and so on, because all these are metabolic diseases. As we age, the number of cells that produce insulin will drop. This is natural. So all of us, if we live long enough, will get kidney failure, we'll get diabetes. So because of that, we have that 3 highs. And as we lose our health reserve, it's very likely and more common to have aches and pains. All of us can attest to it. Arthritis of the knees, and you have a shoulder sprain, and it lasts a long time. Then with that, with your chronic diseases, it increases your risk of disabling diseases and trauma. The loss of independence is the key moment here. Mental issue, a lot of it as we age, is due to frustration, not being able to do what we thought we could do. So that is a kind of loss of independence, but of course you can have range from very mild to very serious. But I can show you also the purple side of it. It's also related to poorly designed physical environment. So you can see there are certain levers that we can also control. With chronic diseases, there's a risk of loss of work and income security. Sometimes just merely because of your age, you cannot find a job. But sometimes because of chronic diseases, your employer may not want to hire you. And when you don't work, income security, especially if you're not affluent, is a big problem. And we want to talk about dynamics. So ageism in the environment, economic development of a country, and how the environment is designed, not just the physical but also the social environment, will impact on the income security, impact on disability and loss of independence. And when you lose your income and the environment doesn't support, you find that you can't help it, but your social circle will start to shrink. When your social circle starts to shrink, for example, a lot of my seniors, they don't attend weddings because they have to give ang pao. They don't go to funeral because they have to give pekim. So and when people ask them out, they can't say it, but it's because they need to be frugal. So losing the social circles and engagement will lead to, together with the loss of independence, social isolation. Alone is not an issue, but loneliness is an issue. Loneliness, boredom. Boredom is an issue. Boredom doesn't feel painful, but if you're bored long enough, your mind is very restless. It will tend to be very unstable. Helplessness is the other issue because you start to lose your friends and all that. And limited social capital is the thing that can aggravate it. Plus, nothing to occupy the mind and our time. If our mind is not occupied, those of you who retire into nothing to do, you can feel it. But those who are working, you find that you're very busy. But actually, if you recall, that is good busy, okay? So without anything to occupy the mind and aches and pains, you have a lot of unmet needs. And negative worldviews and values is very critical. I was talking halfway about the salutogenic theory. One of the most important factors to health is your very dynamic faith in sense of meaning, in the fact that you can manage and things actually make sense. So this, if you don't have that, there's a certain negativity to your worldviews and your values. You have a lot of unmet needs, and it can lead to, it can lead to a lot of, demoralized. Sometimes it's not depression, you're just demoralized. Whatever you do, it doesn't seem to quite be able to help you overcome, and you don't know what is the meaning of it. What's the meaning of this suffering? What's the meaning of working so hard and now being all alone and so on? So there's a lot of stress. So the aches and pains lead to stress. A lot of unmet needs lead to stress. The demoralization lead to stress. And you can have low mood as a result. You may go into depression, or you may preclinical, subclinical, not really clinical depression, but there's low mood. And the behaviors of concern are things like you tend to be negative, you tend not to want to meet people, or you resist a lot of behaviors. And this has impact on formal health system. We talk about people going to hospital. There are a lot of people over-rely on the hospital. Every problem, go to hospital. Every problem, see the specialist. If money is not an issue, they can travel around the world just to do that. But it may not be sustainable to you or to the whole country. Even if you have the money, you find that going to hospitals itself is sometimes doesn't solve the inner need that you have. Impact on caregivers, and that is the next slide I want to talk about. This comes from a very well-known research by Leonard Perlin. He has a model on the dynamics of how caregiver stress happens. Stress, when it happens to all of us, we mediate with our social resources, which when you're young, a lot of friends, a lot of money in the bank, no problem. The other side is the personal resources, your inner emotional resilience, how you work it. If you do it well, you become stronger. If you don't do it well, you actually become weaker. But for a caregiver, what are the stressors? It's caregiving-related stressor. Who you care for, the disability of the care recipient, whether there's mental health issues, as well as your own needs. Caregivers themselves, some of them are aging, you saw in the picture, they themselves have their own bio-psychosocial needs. Sometimes they themselves find that their money is depleting. They quit their work in order to take care of the parent, and then who is going to take care of them when they're old? And then there's also these intrapsychic strains, like is it my job or is it my brother's job? In my youth, my mom always doted on the brother and always, disregard the daughters, and now it's the daughter who takes care of the mom. So it's all of these things that add on to the stressor, and it's related to, of course, the socio-economic background and resources of the caregivers. So I hope to share this in order for us to together collectively look for a solution that's not just about taking medication. Yeah.
Thank you. Thank you, Wai Chong. You know, this thing about caregivers is so important because, if we don't support the caregivers, they themselves become vulnerable to mental health issues and mental illness and the stress. But before we get into that, I'm going to invite Prof. Kwa to share his insights in this area.
Thank you very much, David. I think Wai Chong forget to mention that I feel a bit mentally or psychologically stressed now, trying to give a lecture where all of you are enjoying your food. Usually around 12 o'clock, the brain automatically secretes gastric juice. So our gastric juice of three of us will be churning away while I look across there, chatting, enjoying a food, and this is emotional distress. Can I get back to this one? Okay, I'm glad to speak on a topic, two areas that are close to my heart, aging and mental health. When I first mentioned this topic some 40 years ago in the university, people were not very, people were rather reluctant, because 40 years ago in 1984, I applied for a scholarship or fellowship and awarded a scholarship to Boston, to Harvard, and I was doing something on geriatric psychiatry. And I was having coffee with my friend, a surgeon in SGH. In 1984, there was no NUH. All the Faculty of Medicine was SGH, And he was telling me, what are you going to do in Boston? I said, well, I'm doing something on Alzheimer's disease. He said, Alzheimer's disease? Alzheimer's disease is a white man's disease. You don't find it in Singapore. I said, why don't you stick on to child psychiatry? I was trained in England, in Oxford, in child psychiatry, but I thought I would move on to a different area. So I thought aging is a good area to move into. So when people talk about aging, as you heard from the CEO, there are three things that people thought about, the myth of the 3Ds. If you grow old, you're going to have dementia, you're going to have depression, you're going to be decrepit, meaning you have frailty. Right? But let me tell all of you that we've done about 4 big research in the community now. In Singapore, for dementia, we were part of the World Health Team in 1990, almost 35 years ago. The prevalence of dementia for people above 65 was less than 5%, which means that 95% of people don't have dementia. All right. Very important point, because whenever I tell my doctors to give talks to the medical students, you must tell them something positive. You tell them that all of us will have dementia, all of us will be decrepit. None of the doctors want to do geriatric medicine, isn't it? So tell them the positive side is that although 5% of people above 65 have dementia, and 95% don't have dementia. Second one is to remember, we had a coffee with Minister Ong 2 months ago, and I told him the commonest problem is not dementia. The commonest problem, mental health problem is depression. And depression has a mortality, and that is suicide. And the suicide rate for elderly people in Singapore is the highest in ASEAN countries. Something we do not be proud of. We don't mind having the best airport, the best airlines. Our MRT is not the best now, but we don't have the highest suicide rate. It's not very good, And then decrepit, So in our big research done at Toa Payoh, was finished, then somebody from the Ministry of Manpower rang me. Tell us your results because we want to raise the retirement age. As the results showed that 93% of people in Singapore, people above 65, can do the basic activities of daily living. They get up in the morning, they can dress themselves, they can wash themselves, they can walk, they can bathe. Only about 7 people are frail, they need help, So I said, if you want to raise the retirement age, should not be from 62 to 65, to be going to 67 or 70, Oh, that's too much. Let's keep it at 65, But once again, the good news is most people grow up and they're quite healthy in many ways. But how are we going to capitalize on that? All right. There's 2 other areas I'm going to touch on is prevention. So similarly, in our coffee chat with the minister, he told me that we're having services for mental health, services for elderly. As a minister, the most important thing is, even you have the services, you can't find the bodies. You can't find the bodies, So difficult to get people to want to do geriatric and psychiatry. I could talk to my medical students, I want to do cardiology, I want to do surgery, that's where the money is, Right. So it's very difficult to entice them to do geriatric or mental health. And so I told the minister, the most important thing is, can we have preventive measures? Go upstream to prevent rather than downstream, Last year, I was looking up, I run a clinic in NUS for the students. And I had 2 patients students came to see me who are not only depressed, they're suicidal. So in the evening, I went back home, I sent a message to President Ng Wai, what I'm doing in the clinic is just downstream work, The 2 students are depressed. Why not we go upstream and find out why they're depressed, what's happening up there, and prevent it? Isn't it a better solution? No one is nodding. Are you all enjoying your food? Prevention. For goodness sake, I told the minister, you can build another hospital, cost you about $10 million or $2 billion of taxpayer money. Can we spend much less on the prevention? Okay. We know about this, the rising tide of dementia. Can I clarify a point? Please do not talk about aging as the silver tsunami. It was mentioned once in a conference by the minister, and then during tea time I told the minister, tsunami is a destructive force, Please don't use the word next time again. And the same minister used again next conference, silver tsunami. So I asked the script writer, can you please stop using the word, Because all right. So what we've done in the university, still on ways, new ideas. So in 2004, after I left IMH as the CEO, I was invited to give a lecture at Harvard University. I was thinking of new ideas, and I told my friends that let's think of no use going to Harvard and talk about the genetics of Alzheimer's disease. They are 20 years ahead of us. Let's think of new ideas. And so we thought of something on prevention. And the chap beside me is Professor Goh Lee Gan, the professor of family medicine, because he told me that in the polyclinics, you see some people with memory problems. Can we do something before they tip over? All right? So earlier on, David mentioned about the difference between illness and health. So in the population itself, think of a pyramid. About 3 to 4% of people with mental illness are seen by the psychiatrists in all the hospitals. And then about 10% of them also had mental health problems or sleep problem, mild depression, seen by the GPs, or seen by people like Dr. Wai Chong. And then about 25% of people in the population, a quarter, have some mental health problems. Some days be upset, then last month some of them be worried. There was children going to PSLE exams, anxiety, tension builds up. This is called subclinical, it's not clinical, subclinical depression, anxiety. A big group. During the pandemic, it was worse, you know. People working especially in the front line, in the emergency medicine, many of them have, you say, almost burnt out, but they don't have illness yet, you know. You don't do anything to them, they tip over, you go to depression. So the prevention is more important, okay? So with Professor Goligan, we thought of new ideas because in 1990, NUH, our team was part of the World Health Team for the first global study of dementia. So we had lots of data. So we started a memory clinic in NUH, and a lot of data. We realized that there's a link between dementia and hypertension and diabetes. All right? And I presented that at Harvard, and I told them there's a link between hypertension and diabetes. Oh, then, well, but your sample size is small. We only have 1,000, you know. But now all the data have been done in the world now. It is true, the link between hypertension, diabetes, and dementia. So the first part of it, you're able to control hypertension, diabetes, half the battle is won. All right. So I was very glad when the previous minister, Gan Kim Yong, was on a warlike mood, you know, war against diabetes. Very, very good. Of course, if you can control that, half the battle is won. And we talk about diet, and also we talk about falls prevention. And so we also found that many of the old people who saw me in the memory clinic in NUH, we asked them to do some activities like exercise, they do art therapy, music therapy. They seem to do well, you know. I was doing part of the research on dementia in England at Cambridge. In Cambridge, I asked the professor there, Sir Martin Rolfe, if I diagnose dementia, how long will the person live? It's very important for planning the family, isn't it? He said 5 years. But in Singapore, average about 12 years. You know? And I look after a surgeon, used to be a teacher of Wai Chong, for 17 years with good quality of life. There's something that we can do, all right? So what we did was, because earlier on we talked to, David was talking about the stigma of mental illness, we realized that nobody will come to see you in the clinics. Although we changed the name. In IMH, we call it a psychiatric clinic, then behavioral clinic. When it came to NUH, I said, let's change it to the neuroscience clinic. But now people also know it, neuroscience clinic. So we thought, so I told them, why not move off somewhere else? And we had a good friend who is a very staunch Methodist, Barker Road, Mr. Lee Sun Tek. He said, I heard this rumor that you are going to the private sector. I said, yes, because there's no money. You asked the government for money for research. He said, no money for research, for prevention. So Mr. Lee Sun Tek told me, don't worry, I got a space at Jurong Point. He said, after all, Jurong Point owned by the family. He said, I'll give you a space, about as big as this, you know. The rentals are 7,000. He said, I'll give it to you. And we'll renovate. The renovation cost was 300,000, you know, because of partition it for assessment, you know. And got 1,000 people living around Jurong Point. We assessed them by our psychologists, our nurses. And then we tell them those who are at high risk, because assessment tool, those who have mild cognitive impairment. So we have a phase of normal old people, about 65, then or 60, then pre-dementia, and then dementia. So those are pre-dementia. So it's the first study done in the world on a pre-dementia. In fact, there are 3 centers in the world: Singapore, Paris, and Finland. So we are the third one. So what we've done is we ask them to come down, and then the first part of it, we tell them about health education, all right? Talk about diabetes. Next week, they come hypertension. Next week, about diet. Next week, about falls prevention. And then we divide it in 4 groups. One group doing Tai Chi, another group doing mindfulness, another group doing music and reminiscence, and one group for art therapy. Because we're in a university, you often have to publish research, the top journal of the world. So you cannot just repeat what they've done in Paris or Finland. So we threw in mindfulness, you know, because no one has done it before. You know. And so we did a lot of randomized control study. So so you see, before the old person did the mindfulness, we scan the brain, MRI brain scan. Each scan is almost $1,000. Then 3 months and then 6 months to see a change in the brain. And also we compare mindfulness and health education. The health education was conducted by Professor Goligan, and mindfulness by this man up there, Mr. Wee Sinto, has passed away. He was the best person. So we're head to head. The best teacher in medicine at that time was Professor Go, and then the best teacher in mindfulness. And then we scan the brain and see how, So you see that the top part, the pink one, the health education, the brain of people, be able to condense them together. There's increase after 3 months. Also increase on mindfulness, but mindfulness has much more. So health education do increase the brain cells. Like listening to 3 of us, there should be increasing brain cell. If it doesn't increase in brain cell, it means you are so distracted by the food, or you have just fallen asleep. So boring lectures, It does, right? So what we have done also, we also assess many things, the telomeres and many things we've done. We also have a choral singing, right? It's the music. Because the lady on the pink is Professor Maureen Sarkok. Maureen went for a conference and suddenly she had what they call transient global amnesia. Total loss of memory. Everybody was terrified. Her friend was terrified. Brought her back to Singapore. But being the professor, she went and read all about it. What's the cause? What can I do? She thinks that a good way of preventing it again is to sing, learn new songs. And she, together, and Mrs. Goh Chok Tong, was also part of the team, was the patron. They raised about $400,000 for us to do research. The first study in the world in which you get a random group of seniors at the Jurong area. At the start before the choir singing, we scan the brain of everybody, scan the brain. And then after 3 months, 1 year, And it was so exciting because the friends from Harvard and Cambridge came down to see what we were doing. First study in the world in which choral singing, you can scan the brain to see whether it changes. I'm sure in the Methodist Church, choral singing is very important. I hope you'll carry on. Over at Barker Road, there was a wonderful choir out there. So, wonderful study. And then something on art therapy. Art therapy is the brainchild of my friend, Professor Tommy Koh. Professor Tommy Koh told me there's a study in New York on art and the brain to prevent dementia. So I was then at New York, and I told them that I'm going to the Museum of Modern Art. That's where the painting is, the research is. And I found that in that particular place, they were showing paintings, the original painting of Picasso and Vincent van Gogh for old people. Then I tell myself, I'm sure I was sure our old people, paintings of Picasso and Vincent van Gogh, they will not appreciate as much as I showed a picture of the Singapore River, because it reminds him. So you look at this picture, it's done by a very famous, anyone know that painter? Anyone the name of this picture? The painter is Mr. Chua. This painting is called Apa Nama Awak. So when we showed old people, they know straight away that is Singapore in the 1960s. Right. Because I'm sure some of the seniors here know, in 1963 to 65, Singapore was part of Malaysia, wasn't it? Yes. I told my medical students that. They said, "Are you sure, Prof? Are you kidding all of us?" The medical students, they are top students, of this country. I say your knowledge of history is appalling. So the people there at that 60s, they must learn Malay, so they're tuition class. So the old people know straight away there's time they must learn tuition class. So once again, this study makes a lot of headway with brain scan. So one more study which I did was on gardening. The gardening study was, in fact, the idea of the time the PERMSEC, and who's not a chairman, and he told me that, well, we have done very well in Singapore, our gardens by the bay, we have got 2 million tourists. I told him, I'll be very glad if the old people at Jurong come to the gardens by the bay, because the gardens by the bay is built by taxpayers' money, isn't it? All of us, we pay tax. Why do you worry about tourists? Then they got shocked. Say, I felt a bit guilty. Well, it's always good to infuse guilt into the PERMSEC. So I said, can you bring them, all the old people from your site, the research study, to the Gardens by the Bay, and we'll pay for the bus fare, we'll pay for entrance, and we'll pay for high tea. Wow, that's a very good. I told him, I'm actually a researcher. Can you give some money and we do a randomized control study and we measure over 6 months, besides going to Gardens by the Bay, teach them some gardening. All right. We also take the blood to find out whether gardening improves the immune system. The paper was published in the top journal of the world called Nature. In fact, when it was published, the BBC rang me and said, can we have an interview? Is it true that it improves the immune system? So after all this, within the 5-year point, you find that the depression rate of old people used to be 9%, half. And the depression rate is only 3%. The government's report is 10%. 10% for people above 60 years old. In Singapore today, we have almost 1 million people who are above 60 years. 10% means 100,000 cases of dementia. Can I repeat? 100,000 cases. If you do this approach, which is a non-drug approach, you bring it just to 3%. The amount of people we save is about 70,000 people you've saved. That's tremendous, isn't it? Yeah? I was telling some people, they said, well, in Singapore, you must monetize your research. To impress the government. 70,000. My medical student did a study. If you diagnose someone with dementia until the person passed away, the cost is about $12,000. 12,000 over 10 years. So 12,000 multiplied by 70,000 comes to about 840 million. This is a study done together with Professor Houston Hua, the economist of NTU. So think about it. But Houston Hua told me, what you've done is a direct cost. You didn't factor in the caregiver's stress, like what Wai Chong mentioned. Right? So caregiver stress is tremendous, right? So it's no use just doing a research in Jurong and then forget about it. We extend it to many, this is called translational research. You extend it to many centers. Now there are 20 centers in the island doing Age Well Everyday program, a non-drug approach that is doing very, very well. Our neighbors, Indonesian, invited us to go over and talk in Jakarta, Surabaya, and also in Malaysia, in Penang, KL, Batu Pahat. Anyone from Batu Pahat here? Oh, good, good, good. That's my hometown. I'm glad. Once again, I asked a patient that came to Batu Pahat to see me in my clinic and asked a medical student, do you know where is Batu Pahat? And these are the RI boys. Is it near Penang? One more say, is it near the Kuching? Say, once again, your geography is appalling. Something must tell the Minister of Education. Nothing to do with education. So, okay. So now what we're going to do, something, a challenge to all of you. What can the Methodist welfare services do? I think there's something you can think about aging in place. This is actually the idea of Mr. Lim Boon Heng. He told me that the big problem now is, can people stay in where they are living? Must all of us end up in old people's home? There must be some ideas. So I told him that there are two things to think about. So we did a study called Community Health and Intergenerational Study, in which how to build up bonding with the family, and also how can the community, the volunteers coming. So I was trying to instill in people. I've tried in some churches. They say, okay, fell out the whole ideas. Maybe the Methodist group will be much better than the rest. The Malay group are wonderful. The other group are the Kong Bin San group. Very, very strong. They go on, help each other out. So there's one other study done by Dr. Shifali, a nurse, called Where There Is No Psychiatrist. So, for example, if you do a study on depression, you found that many people have subclinical depression and people going through a grief. Can you help them out? Must it all the time be a psychiatrist? An appointment to see the psychiatrist anyway is 6 months. How can you do that kind of thing? Can people be trained? I'm sure we can train some of you. I'm sure we can train David to provide some psychological first aid. Where there is no psychiatrist, David can walk in and do something. And he knows when to refer. When he can't cope, he refer up. If he can manage, wonderful. So I think what we are doing is now, it's not just changing behavior, but changing values. Caring, empathy, compassion. These are things that we're going to do. I discussed this matter in a World Health meeting. They say it's difficult. Because it's difficult, let's try it. Behavioral change is not too difficult. My friend, Dr. William Wan, told me that the kindness movement man, remember Dr. William Wan? Also, he was telling me, I'm trying to convince Singaporeans that why not we bring our tray from our hawker center to the trolley, and people don't do that, and until the government said, you don't do that, $50 fine. Straight away change the behavior. But values, caring for a neighbor, caring for even your own family members is a bigger challenge for all of us. So something we can think about. All right. So all the things that I've talked to you is in a book called The Colors of Aging. Has anyone read this book? Besides Jialing? Yes, right. Good. I'm the Methodist, I'm quite disappointed, all of you. This book was reviewed in the British Journal by the professor from London University, and his opening line was, this book should be read by Bill Gates. Because Bill Gates, 5 years ago, before the pandemic, he told the world that I will give $100 million to whoever can find a drug for the prevention of dementia. The professor from London said, you can never find a drug. You should read this book from Singapore. Because dementia is what we call a syndrome. It's due to many causes. Right? It's not like COVID-19 or malaria or tuberculosis, a bacteria. You can wipe it off with a drug. Dementia is we call it a syndrome. It's due to many causes that comes in. Just like schizophrenia is a syndrome. All right? Last night we had a long discussion at 9 o'clock, the big webinar. People talk about schizophrenia as a particular illness. No, I told them it's a syndrome, many causes to it. We must tackle different areas. So, okay, I hope I've not spoiled your lunch. Thank you very much.
Thank you, Prof. Kwa. Thank you, panelists. That was very insightful. But one of the issues with health always, with seniors especially, is getting our seniors, our parents, all right, to accept that their condition is actually deteriorating. So if you see that in a loved one, a parent or an uncle or an aunt, and any wisdom as to how we can actually get them to accept that, they have a condition that perhaps, needs help. Because they will always say, I'm fine, what are you talking about? Any thoughts?
For some of you would know that there's a line in the New Testament, 2 Corinthians 4. It says, your outside body may be withering away, but the inner self is renewing. Yeah. So the thinking can still continue. All right. So one of the most difficult tasks is to tell a colleague. I got a friend of mine who I mentioned earlier on, as professor of surgery. To tell him that you actually have dementia, and but how to go about doing that kind of thing, tell your friends, a good friend of yours that I have to go off from the early lunch because I have an urgent referral to my clinic. Someone, also a close friend, the wife said he has dementia, but how do you break this kind of bad news to people, So for this surgeon, I told him, I'm not going to tell him point blank, look here, you have dementia, not tell him that you have a memory problem, But I'll tell him the good news first. The good news is we can do many things to improve your quality of life. That's what people want to do. And good news is I can tell you that if you have dementia now, from our research, we published the first paper in the world on the natural history of dementia. If you have dementia now, when do you think you will end up, or each phase, mild, moderate, or severe? I can let you know about it. So he was quite happy about it. I said, okay, we'll do certain things, keep the hypertension, diabetes, and you can carry on your exercise. So give them some hope, Well, they say when there is no hope, the doctor must prescribe hope, Tell them there's something you can do. So this particular surgeon was very good because once he was very disturbed, and then the wife rang me and said, can you come and see him? He's so disturbed, So I went to the house, not far from here, in fact, And when I entered the room, at the back, he was very quiet now. The background was the music, a piano piece of Beethoven Moonlight Sonata. Then I went to him and said, you seem very keen on this piece of music, And he said, the Moonlight Sonata reminded me of London in 1953 when he passed the exam for surgery, the FRCS. In fact, you're the first Singaporean to pass the exam. He said, I was so happy. I went down to London City itself. I went to Whitmore Hall and I bought a ticket. And I entered the hall and the man was playing the Moonlight Sonata. So it gave me an idea of music reminiscence. So from there, we did a study in Jurong. So there are many things we can do, in terms of telling people. Always tell them the good news, even for cancer patients. I tell my friends in oncology that if you see a patient with cancer, don't tell them, I'm giving you this drug, you'll lose your hair, will loss, you drive, you have no more sex drive, finish. Nobody will take your drug. You just tell them, you take this drug, you will shrink your cancer, you can breathe better. All right. Anyway, there are also side effects. Tell them the good news first. All right.
Wai Chong, you wanted to add something?
Actually, the point I wanted to make is what Prof. Kwa has been saying. A lot of time for seniors, of course they're deteriorating, they also know it. You don't have to really tell it to them, because once you actually diagnose or confirm it, it's really a surest way to disempower a person. Like, how do you feel if now I'm confirmed I've got dementia? If you haven't told me, at least I roughly know, but give me the time for myself to really get to know it. So the way, for me, when we take care of persons, especially who are frail, vulnerable, and all that, we really need to give them the power to pace it. So as a doctor, to communicate, you should spend more time listening to what is the unmet needs. Help them to meet the needs. No need to rush to diagnosis, but of course one day they'll find out from you, and they'll need to know when the time comes that they need to be clear, then provide the clarity for them. But there's no need to diagnose. We actually work on meeting the needs.
Did you want? Yeah, Raymond.
So I think to add on the two points, right, is that I think very importantly is the caregiver also, the caregiver, because normalizing the conversation about dementia or mental health, it is sometimes very difficult to get the understanding of the caregiver, and the caregiver are also having immense challenges in trying to rationalize and trying to come to terms with a loved one getting dementia and mental health issues. Yeah, and a lot of times in our line of work, especially MWS, where we have a home care, home hospice unit, where we do home visits and engage the families, is that this is essentially one of the biggest challenges that faces our staff. So, and sometimes family members cannot come to terms, that's one. Some members may not fully understand the condition or the trajectory of the condition. And like what Prof. Kwa, when we tell them the good news, the caregiver will say, oh, we know the good news, but I'm dealing now with my family or my family member 24/7, and I see the bad side as well. So how do I rationalize with that? How do I come to terms with that? And how do I mitigate that? I think that's the very important part of this whole care journey, that when a senior declines, the caregiver is also there. Like, and those two videos that we saw, those were very visceral, right? It's very close to our hearts for those who have taken care of family members before. So I think that, and to mitigate that, no, it's a wicked problem, as we say, but awareness, education definitely would be the start point, right? And then with all the services that are out there, to then continue to support the community folks to be able to journey with the seniors as they go on the journey of aging. I think that is something that I wanted to add. Yeah,
Thanks, Raymond. Any questions or comments from the floor? I'm sure that the panelists have provoked thoughts in your minds. My wife. Someone got a mic for her, please? Coming. Okay, I'll introduce her while the mic is coming up. This is my wife, Swee Kwan. She's going to tell you about ballroom dancing.
I was really interested to know that gardening and singing is amazing. Actually, I'm quite active on my own. I reach out among the unchurched. So you won't see me reaching out in the church because they're full of helpers. But the unknown, unchurched people, there are plenty, and they really, really look forward to all that you have described, the aging activities. And one of the things that I do is meeting people very naturally and showing the love of Christ without preaching hard. And that is my mission. And I have a joy being forced to ballroom dance by my husband when I was very young. I'm quite old-fashioned. I was from a brethren background, and I can't even look at a man's face how to dance, right? But anyway, he changed. He's the most patient guy that I have ever known. Patiently waiting, and he waited 15 years. And today, my outreach is among that group, and I have really wonderful news to say. Even this 96-year-old lady is still dancing, and she can rock even more than me. And okay, she has forgetfulness. I don't want to say dementia, but she can argue and win an argument. She will never let you go. But the beautiful thing is that you didn't mention, by the way, ballroom dancing as part of the activity, like gardening and music.
You can add that to your slide.
So I'd like to know about that. And secondly, is it true that golfing is zero help to dementia? So just putting this aside, it will be a tremendous help. Okay?
Thank you, Sui. Prof.
Right,
Kwa,
thank
I
you.
can't answer that, so you have to answer for me.
Sure. So in fact, a number of seniors are doing ballroom dancing as a way, and it may seem quite simple, but it's quite intricate in the steps you got to remember. Jialing, remember, I was asked we're supposed to raise money for, I'm quite a number of donors here, and they say, well, this year's event, can you also sing and then dance? Sing is not too difficult, but to dance, the coordination can be more difficult, So, but it's very good because you learn new things. The brain cells begin to grow. The coordination, learning new things every day is wonderful, all right? And it's wonderful because I see quite a number of young people here, which I want to convey to you. When we published the big paper in the British journal, The Lancet, the reviewer said, starting dementia prevention at 65 is too late, Can you ask them to start earlier? So as to get the good news to all of you. If you start early, it'll be wonderful, that we may bring it down again. All right. So ballroom dancing will be wonderful, and she can teach you. They can do a long-term follow-up study, Yeah. Thank you very much.
Yeah, apart, from the dancing, apart from the physical aspect of learning your steps, it's the social interaction. Okay, it's a social activity. And that really helps with the elderly. Any other comments or questions from others? You can use pigeonhole or you can stand up. It's, of course, nicer if you speak and share your thoughts or questions. Someone there? Don't be shy. Anyone? I've got here a question that aging is an inevitable process for everyone. All right, we all get older. What can we do to build up general mental resilience and strength, to try and delay the onset of, say, dementia? Or any thoughts on this?
I just give the lecture. Who asked that question, by the way? He fallen asleep, is it?
So it's all the, the nice thing about it is you can do the gardening, the singing, right, and all this stuff. These are the things that really help. You don't need to take tablets. You don't need to see a doctor. These are social activities. But the other thing I would add personally is, the family support. Actually, family support does help, elderly cope with their situation. And that certainly helps them avoid many of the symptoms of mental illness. Anybody want to comment on that? Yeah.
So, thanks, David. So I think there was couple of points that I sort of intrigued me was in terms of mental health, right? I can share some statistics with the audience, which is quite interesting, right? So, Sing Health actually came to me as part of the Healthier SG initiative. And one of their challenges was that men, did not actually subscribe to the Healthier SG. Interesting, right? Did anyone know that? The enrollment rates for, I'm sure the whole audience here, most of us, if not all of us, above age of 40, right? You will have received an SMS to say that you're eligible to be part of the Healthier SG. Please go and see your closest doctor. and you can get a free health plan done, right? You all got that, right? All of us got that. And interestingly, Sing Health told me that the enrollment for males was 12%. 12%. All right? And females was way above that. Way above that. So why is this so? Because the health-seeking behaviors were very different. And back to Prof. Clark's point was that, that lecture that you gave, amazing, was when you link physical disease and mental disease together, there is a link to that, right? So when you don't have health-seeking or preventive health-seeking behaviors, that will certainly be an issue, especially for men. And I'm actually very glad also, I think I may have some fellow colleagues here from MWS, that we actually initiated a men's only happy hour at our AACs, at our active aging centers. And the men only happy hour was initiated specifically also for the reason that the men were not going to our AACs. So I don't know, is men an issue?
Thank you.
Yeah.
Okay, I've got a couple of quite specific questions here. Okay, someone here says, what is the government doing, and what are the financial assistance for caregivers? All the measures that have been shared, is the government taking the lead? Anybody want to comment on that very briefly?
I think sometimes must give credit to the government, although we like to be unhappy with them. They've done quite a lot. Compared to 1984 when we started here and now, there's quite a lot of changes now. Even a big discussion here on aging, a lot of services been coming. In 1995, I was in Washington, D.C., the National Institute of Health wanted to do a big study, a global study on suicide in the elderly. And I took the data from Singapore and for the last 5 years, and the suicide rate in 1995 in Singapore for elderly Chinese men was 62 per 100,000, the second highest in the world. It came out in the newspaper, it terrified the minister, and she rang me about. But after that, they did many things. You have day centers by your Presbyterian group, Muslim group, and the suicide rate came down, very fast. But now it's on the rise again. So the minister himself asked me, I said, I'm not too sure what is it about, why is it on the rise? But there are many things you can do. If you can bring down the depression rate, then you can bring down the suicide rate. A very good point that David mentioned was the dancing and even our choral singing. The best result is not the MRI brain scan, that attracted attention in the World Health. The best result is the people began to know each other better. The social connectedness at the Jurong area was wonderful. The young, old, those between 65 to 74 began to care for the old. Before they know that Mr. Tan is at level 2, Ahmad is somewhere, but now when they sing together, they know each other better. They care for one another. So these are things that you can think about, that many things can improve. Of course, we want the government to do some more things. I remember going to ask the government for money for the prevention program. They said there's no money. I said, what do you mean no money? Now they're trying to give us some money now, which I'm very glad.
I'll just comment on what the government has been doing, because I've been in this for the last nearly 30 years, and I've also traveled the world to study the different aged care system. I must say that the Singapore government, since particularly 2011, when the Interministerial Committee on Aging came under the auspices of Ministry of Health, when somebody really owned it, and a ministry that owns a lot of budget, become the secretariat for this particular interministerial work group under the Aging Planning Office, I start to see really, really concrete differences. So what are the examples? One example is 2015, we have the blueprint for successful aging that became viral on the internet, and last year this was revised. 1st of January or 31st of January was published as the update of the blueprint for successful aging. And last year there were 3 other strategies that were being developed that's related to aging and mental health. The first one was the strategic policy strategy related to frailty. And then in October there was a strategy related to palliative care, or July. Then October was a strategy on mental health. So with strategy came action, and of course after action, structure, teams and so on, then there's funding. And now they and we are working, I say we because I'm a Singaporean, but we are working on a strategy for caregiving support. So even somebody asked about caregiver support, there are altogether 5 things. So there's the healthcare home caregiver grant is now not just payable to you to help you pay for a maid. You just pay to anybody at home who is a caregiver. And then there's respite services. There is a lot of caregiver training courses, which has just been revised last year. And then there is a navigation system online. And lastly, there's one on, I can't remember the 5th one, but there is one related to focus on caregiver, not just with respect to caring for the care recipient, but what do this caregiver need? So focusing on treating the caregiver as a care recipient herself. So because we know, if you want to take care of a senior at home, the caregiver is the most important elephant in the room. If you don't take care of the caregiver, you can't take care of any senior. So there are many things that's on the way, and looking at least Asia Pacific region, we are really at the top. Maybe Taiwan is up there as well. Japan, because of the severity of the aging, their innovation is a bit too late, too little now. But Singapore, Asia Pacific, we are really up there. In the West, all of them are now going backtracking. It cannot be just taxpayers. Caregivers need to do something, and now they want to go back, but a lot of caregivers no longer see it as their job to take care of their parents, so it's a bit too late for that as well. So Singapore is really top, quite up there in terms of our aging policies.
Thank you. There are quite a lot of questions. There's someone that said, how do I get a clinical diagnosis of dementia? My mother's neurologist does not want to confirm it for whatever reason. Is it genetic? How does one get a clinical diagnosis of dementia?
I think in 1990, when we set up the first memory clinic in Asia, in NUH, in the clinic, there was a psychiatrist, a geriatrician, a neurologist, and a psychologist working together. So we from there, we have a meeting to discuss, because dementia is a very powerful diagnosis, because once you're diagnosed dementia, in some ways your civil liberty is taken away. You may not be able to sign check anymore. So or your rights are taken away. So one has to be very careful. So I tell people, you want to make a diagnosis, you got to think through, discuss with your colleagues until you're very, very sure, because it involves mental capacity now. You have no mental capacity, you can't even draw a will. So we do have it, and I'm very glad now. In most hospitals have their memory clinic now. You can go to one of these places. Yeah? All right. And it doesn't mean that if a family member has dementia, therefore you will have dementia. It's not a dominant gene. All right. It's not dominant. All right. Sometimes you skip generation, but there are many things you can do. All right.
Someone congratulated you, Prof. Kwa, on your presentation and asked, all these measures, singing, art, gardening, do they just delay or postpone the onset of the disease of dementia, or can you actually correct it?
Yeah, right. Well, that's a brilliant question. Yeah. After praising me, it's a difficult question. I thought you'd say, all of you have done so well. It's time for you have your lunch now. So anyway, what we've done is we try and find out how. Now, by the way, whatever we do, we cannot prevent all dementias, right? We can bring it down from 10% to 3%. There'll be some groups we cannot touch. We can never prevent them altogether. So there will be some people who run strongly. I mentioned the surgeon who have dementia. I look after the 2 sisters, also have dementia. Run through the whole family. It's very sad. But they're very well taken care of by their family members, and friends, all came down together. That one is a dominant. It runs in a family, and all of them had it. But some families you skip the generation, right?
Thank you. Perhaps a last question here. Someone has pointed to Denmark as having an example of a development where old and young live together. So the question is, how do we encourage our seniors to interact with the younger generation more? Is it possible to do something, in this line, mutual caring? Any ideas, thoughts?
I think Asians should be proud of the family, isn't it? Asian.
Yeah, family.
We are so proud we talk about filial piety. I think the family is a bit disfragmented now, but that's why I mentioned to you about aging in place. Can we build up intergenerational bonding? Maybe Methodist Welfare Services can think about this as a possible project for Raymond. I think besides just doing services, something can do, and now also the volunteers helping out. I think the other models used in other countries, whether people live together or even day centers have young and old together. So that's very good. Something we can learn from each other.
Thank you. Well, I have to bring this panel to a close. I want to thank all of you for your questions. Very sorry that we couldn't get to all of them. And I want to thank the panelists for your insights. Much appreciated.
Hi everyone, thank you so much for still staying on. I'm very glad to be given this segment because at least I get to eat my lunch. I feel so sorry for the panel because the lunch has been served to them and it has gotten cold, but I'm so glad that I could still eat my lunch and I could at least still eat my dessert. A very big thank you to MWS for inviting me to share my thoughts on leaving a legacy. And so I only have got 20 minutes. So I hope that in the next 20 minutes, I will be able to share with all of us what is legacy planning, what is not legacy planning, hopefully share some lessons that I have gleaned from the work that I've done with clients with legacy planning. And hopefully by the end of the 20-minute sharing, I hope it will trigger some thoughts for yourself, even as you plan for your own legacy. So let's start. In my world, and my world is the wealth management world, oftentimes when you talk about legacy planning, it is always associated with things such as universal life insurance policies, the will's instrument, or trust. But this is not legacy planning. These can be tools that are used for legacy planning, but they are certainly not legacy planning. And also in my world, estate planning and legacy planning, they are often used interchangeably. Although there are some overlap, but there are subtle differences between estate and legacy planning. So let me start first by explaining what is estate planning. So estate planning is about the management of a person's assets and liabilities upon his or her unfortunate demise, and it covers areas such as estate creation, which is really about making sure that when we passed on, we want to make sure that our families, they have got enough assets to live life as normal as possible. Secondly, in estate planning, we are talking about estate preservation. And estate preservation is about making sure that whatever we leave behind for our families, we give to them, or rather we maximize whatever we leave behind for them, avoiding leakages such as costly probate costs or unintended tax like estate duty. I know we have no more estate duty in Singapore, but if you have got assets in overseas jurisdiction, you may potentially have to pay for estate duty and some other costs. So in estate preservation, we are trying to minimize these costs. And of course, the third area in estate planning is estate distribution. And it's all about making sure that whatever we want to leave behind for our families, our loved ones, it goes to the intended beneficiary. So that's estate planning. But legacy planning is slightly different. Legacy planning is the process of creating something enduring that can be passed on. It is the enduring impact you leave on others and the accomplishments and contribution that people remember long after you are gone. And I hope we see the subtle differences. It doesn't have to be physical assets that you are leaving behind. That's more estate planning. Legacy planning, you can pass on things that are intangible. And in fact, it is meant to pass on things that are intangible, like values and all that. It is about creating something that outlives you, whether it's through your family, your professional work, your mentorship, or your community involvement. So I hope after this session, we will now know what is estate and what is legacy planning, and really they are quite different, although I would say that estate planning can be part of legacy planning. Now, I would like to share some of the lessons that I've learned in the work that I've done for my clients over the past 26 years. And most of the work, or most of the lessons that I've learned that I'm going to share today, they refer to clients who are a lot wealthier. And I'm not saying that only the wealthy should do estate and legacy planning. No, I'm not saying that. It is just that because of the work that I've done for some of these very wealthy clients, I thought the lessons can be very precious for us to learn. So, let's go to the first lesson. Now, the first lesson that I've learned is that giving our children too much in life at a young age may not be a good thing. In all the plans that I've done for my clients, one common request has always been to protect their children from squandering away their assets. And that is always a common request. And this is not just limited to beneficiaries who are young. They apply also to beneficiaries who are pretty old. I've done structures for clients who wants to prevent a 50-year-old son from squandering the assets. Now, why is it like that? Most of the time, it is because these ultra-rich individuals have unintentionally spoiled their children. When they were young, they gave them very expensive cars, expensive bags, expensive trips, business class when they were just toddlers. And I'm sure it is not the parents' intention to spoil their kids. No sensible parents would want to spoil their children. But unfortunately, unintentionally, it starts from something small, and by the time it snowballs to something big, it is often too late. I recall a gentleman whom I have planned for. This gentleman has about 40 to 50 real estate properties and many other assets. And as part of his estate planning, he decided to set up a trust structure just for one son. The rest of the assets will be distributed by a will outright to the rest of the children. This one son is in his 40s, was in his 40s, by now he's slightly older. And in the trust structure, the asset is not given to him as a lump sum, but streamed out as a monthly income for as long as he lived. And when I dig a bit further, I realize why this is so. This son is employed by this very senior gentleman with a job in his company. And this gentleman told me that the only time that this son will get up from his chair in his office is when he gets up to go to the toilet, to eat lunch, and to go home. The rest of the time, he's sitting at the desk playing computer games at the age of 40 over years old. And I was shocked. But I'll tell you that I have got many even more shocking stories to this. I have got matriarchs who set up trust structure to pay utility bills for their 40-year-old son or children or that child. And when I ask them, what happens if you don't pay for the utility bills? Well, the electricity will be cut off. And some of these children, they have got great education from premier colleges around the world. And so it's quite hard to believe. Anyway, that's the first lesson I have learned. And no wonder I think it's why King Solomon said in Proverbs that an inheritance given at an early age may not be a blessing in the end. First lesson that I've learned. The second lesson that I have learned is don't just build your wealth at the expense of building a relationship with your loved ones. One of the common observations that I've seen is many are ultra-rich. They may be very successful in their careers, they may be very successful in their businesses, but they may not be necessarily happy, and they may not be successful in the relationships. And a lot of reasons, a lot of time it is because they spend too much time building their wealth and that they have neglected their loved ones. Early this year, I was introduced to a senior gentleman in his late 70s, and I went to see him. This gentleman has sold off the business, and he has a net worth of above $200 million. So I was asked to put in place a plan for him when he passed away. I found out subsequently that he stayed in a beautiful 2,600 square feet luxurious apartment on his own. He's divorced from his wife. He gave his wife a beautiful bungalow, which his wife stays alone. And he has 3 children. They are all estranged. So when they reach their old age, they may have the means to live a luxurious life, but they are lonely. So that's the second lesson in the work that I do. And many of these lessons are not isolated cases, by the way. The reason why I took them out is because I've seen just too many of these cases. I'm sure many of us have watched this tear-jerking movie, because this tear-jerking Thai movie took Singapore by storm a few months ago. How to Make Millions Before Grandma Dies. If you have not watched it, congratulations, because you saved some money. You can watch it on Netflix today. So my wife and me went to watch it. I'm not going to spoil this movie for you, but I'll just say that the gist of this movie is about how 2 sons of this grandma try to scheme and inherit the property from this grandma when she passed away. And this grandson that you see had the same idea. He quit his job to take care of the grandma with the hope of inheriting the property when the grandma dies. But at the end of the movie, it shocked all the moviegoers when this grandma decided to give the property to the son, the most quote-unquote useless son, who was beset with debt, and the grandma decided to give the property to him so that he can sell it off and pay off his debt. But after the funeral, this young man received a call from the grandma, from the bank, to tell him that the grandma actually set aside a large sum of cash which she has been saving all these years for this grandson. Okay? I don't know why you're laughing. I thought it's quite touching. I don't know why you're laughing. It's quite anticlimax, by the way. Anyway, so while many people were debating whether the grandma made the correct decision, my wife and me had a second, we thought quite differently. Well, we felt that as much as we love our children and we want to give them the best, I think we have already given them the best in our lifetime, right? We think, at least between my wife and me, we felt that, we should set aside some money for ourselves to spend meaningful time with each other and also to do meaningful things with each other. Many of my very wealthy clients, even though when they have estranged children, they still try, or they have children that they feel may squander away the money, they still want to give everything to the children. Now, I'm not stopping us from giving things to our children. I'm just saying, spend some wealth on ourselves, don't just leave everything for your children. I hope you are not one of those children of rich parents here today. You will hate me for saying this. The fourth lesson I've learned is that in your legacy plan and your estate plan, do not just give away your wealth, share your message. Because in all those plans that I've put in place, every single plan, there is a love message. Every single one. Even though some parents are very heartbroken when they do those plans, but every single plan has a love message. But unfortunately, the love message is buried in the complicated and legal languages in the wills and trusts. Because you don't expect the will and trust to move the hearts of your children, do you? Even when they write their letter of wishes, it is written in a very legal language. So I often encourage clients that when they put together their legacy and estate plan, sit their beneficiaries down, and whilst they are still alive, explain to the beneficiaries why they are doing this. Because that's the best way to leave behind a legacy. That's the best way to tell your beneficiaries that you love them. Although it's very tough in Asian families to do that, I understand. Yeah? And if you can't do this, then one way to do this is to write your own letter of wishes. Don't get the lawyer to write it. If you are lawyers, I'm not trying to say you can't write good letter of wishes. But nobody can write a better letter of wishes than yourself, because you write it in your own language. You write it with your not so good grammar. But because it is written that way, your children know it's from you. And that's the best way to write the letter of wishes. So don't just give away things. Leave a message of love. Share your message, if possible, face to face. If not, through the letter of wishes. The fifth lesson that I've learned is this. Consider giving to causes. I have no clients that I have seen that come to me with the first intention of giving away their money to charities or to causes. None. In all these 20 years, I have no clients that come to me and say, firstly, I want to give this amount of money to a cause that I believe in. It is usually an afterthought. And it is usually only when I tell them that perhaps, Mr. Client, you should have a secondary beneficiary. Why? Because if you do not have a secondary beneficiary, you can put up this trust, you can set up this trust, your 2 adult children can come together, collaborate, and close the trust. And whatever plans you put in place will be useless. I know that sounds shocking to you, but there have been a previous case, there have been precedents, and you know we are based on case law, right? And there's a case called Zonder versus Voltaire that but because of this case, there is a possibility that 2 adult children can come together and close the trust. But if you put a secondary beneficiary, they can't do it because if these 2 children passed away, then the assets can go to the charity. So it's usually an afterthought. Okay, never mind, I'll give to certain charity, just in case my children, they are not around. And it is sad, isn't it? And all these years, I think charitable giving is not very popular in Asia. But I'll ask you to consider giving to good causes that you believe in, because it's one of the most tangible ways to create a legacy. It's one of the most tangible ways to tell your children what matters to you, right? Because you're putting your money where your mouth is. I'd like to end by sharing the story of my mother. On the left side, that's my mother. Isn't she pretty? Just say yes. So that's my mother. So my mother is one of the 5 daughters in the family. But unfortunately for her, she was given away when she was young, and in the olden days, I think it's quite common. The parents don't have money, and so she was given away to I call them my grandparents, but it's the adopted parents of my mother. But I'm so grateful today that she was given away to this set of grandparents, because this set of grandparents really love me a lot. I do not know how my mother felt when she was given away, when she was chosen to be given away. She was number 3 in the family, amongst the siblings. My mother subsequently married my father, and my father became a bus driver. So I grew up in a family with 3 other siblings, and we didn't have a lot of money. But my mother never made us feel that we were poor, because whatever that her hands touches, it became very nice food for us. I remember that when I was young, my mother would always bring me to the market very late in the morning, like 11 a.m., because, of course, at that time I didn't know, but subsequently I found out it was because that she could buy things very cheaply, especially those vegetables which nobody wanted. Right? They pick, the hawker will pick it, and then the remaining vegetables, that's what my mother will buy. But, as children, we never knew this. And of course, when my mother whipped up the dishes, it tasted delicious. And it's not because it's comfort food, it's not because I'm biased. Many people who ate my mom's cooking said that she is a great cook. The second picture that you see is a picture of my mother's 81st birthday. And that was the last birthday she celebrated, because subsequently, a few months later, she was diagnosed to have lung cancer. And we thought that she would live for another 6 more months or 9 more months, but by God's grace, in 3 months, she passed away. Of course, we were very sad, but I said by God's grace because my mother never had to suffer any pain at all. Right? So we were preparing to visit her when in the afternoon when the hospital called us and said that, your mom has passed away. And when we rushed to the hospital, well, this was what we saw. The last picture that you see is a picture of my mom, but she has already passed away, and she seemed to be sleeping very peacefully. My sister zoomed in. I do not know why she zoomed in, but she saw tears in my mother's eyes. And that initially affected me a lot because I thought, no, she must be in pain. And I have a Christian brother who came to me and encouraged me and said, no, because some years back, my mother had that privilege to accept Jesus as her Savior. And my Christian brother said that that was tears of joy because she saw Jesus receiving her to heaven. So, what did my mother leave behind for legacy? Because my mother obviously didn't have much money to give behind. My mom's legacy, I would say firstly, is this. It is her thriftiness. That's the first legacy that my mom has left behind because, like I said, throughout my mom's life, I've seen how thrifty she was. Secondly, my mom was very encouraging. Throughout my studying years, there was never once that my mother pressured me to do well in school. My mother only had 2 advice for me. First, don't mix around with the wrong company. Second, just pass every year. That's all she said. And that's what I did. Every year, I just make sure I pass, and I graduated from university. And this is the values today that apply to my own children. I've got 2 adult children now, one 26, one 22, right? And I gave these same two advice to my children. Don't mix with the wrong company, and just make sure you pass every year. There was a time whereby I thought my daughter wouldn't pass, but she graduated last December from university, right? So then one day my daughter told me, my daughter said, when I grow up and when I get married, I want to parent my children the way you all parented us because we never gave them any pressure at all in their studies. But where did they come from? Where did that come from? It came from my mother. The third legacy that my mom left behind for us was her generosity and her kindness. During her wake, many people came. Some people we don't even know. One of them was our neighbors. Of course, we knew her. And she recounted those times whereby my mother would volunteer to take care of their kids without charging her a single cent. And my mother was really quite busy taking care of 4 kids, but she volunteered to take care of 2 other children. And so we learned generosity and kindness from my mother. And of course, she left behind great recipes. Some of the dishes here is not cooked by my mom. The chili, chicken, and the fish maw soup was my mom's specialty. But my sister inherited it. And so every Chinese New Year, we eat it in remembrance of her. After my mom was cremated, we went back home and we tidied up her belongings. It was when we realized that my mom didn't have much. She had only a few pieces of clothes. She had a stash of cash, a few $1,000s in the drawer. And she used to learn embroidery, and she had some of her pieces of her work. And so we decided to redistribute among ourselves, and the few $1,000 after we divide among the 4 siblings, each one of us have a few $100s. That was the financial legacy that my mother left behind for us. Not the millions of dollars which I've shared, but the values that she has left behind, the harmony in the family. And the reason why I share with all of us this is because do not think of legacy planning as just something that the ultra-rich will do. And I've shared those lessons that the ultra-rich have done. A lot of the legacy planning are just estate planning. But legacy planning is more than estate planning. And legacy planning cannot be achieved by a simple trust, a will, or buying an insurance policy. That is not legacy planning. Creating a legacy takes a long process. It's what we do on a daily basis and what our children observe us to do that creates a legacy. That is true legacy planning. You see that ang pao there? That was my last ang pao that I gave to my mom. 2 months later, she died, and then she never even took out the money in the ang pao, so I decided to take it back, and I never even spent that $50. I can't remember how much money I gave to her. Fraudulent sleep. Okay, it's $50. No, I don't. I think it's $80. I gave to my mom. I kept it as a memory. That's her legacy for me. I just have one last slide to show you. This was the final moment where I had the privilege, because I was the only son in a family amongst 3 other sisters. So I was given the privilege to close the coffin, the casket for my mom. And when I looked at her, I thanked her for being my mother and for the legacy that she has left behind. And I wanted to show this picture because we will all have this final moment. All of us will have this final moment, and we'll all be there in the casket. And our loved ones will be there to close that casket one last time. The legacy that we leave behind is what our children tell us, and the loved ones will say. That's legacy. And like I say, that cannot be easily done through a piece of paper. That cannot be easily done through a financial instrument. So I hope that gives us some understanding of what legacy planning is, what is not legacy planning. I hope some of the lessons that I've shared from the work that I've done will hopefully help us to reflect on how and what kind of legacy we want to leave behind for the people that matters to us. With that, thank you very much.